Thai audience, and also good evening, Dr. Wu from Indiana University, Indianapolis. Hi, welcome everyone to iAOC course series, Professional Development in Advanced Imaging during COVID-19. And this week is the last week of the module 2, and this is a special session for Neuro Radiology 101. And we get Dr. Wu agree to give a talk, and this is my great pleasure to introduce Dr. Isaac Wu, my friends, my teacher, my mentor from Indiana University School of Medicine, Indianapolis, Indiana. We have known each other, I think it's like more than 10 years since I was a first year fellows at Indiana, and you started your career as a teacher, and after you started the career at Indiana University, you won Teacher of the Year 12 years in a row already.
I don't think
from your first year, right? So today, Dr. Wu gonna give us a talk about neuroimaging for non-neuroradiologists, then the intracranial mass effect. So this is a good lecture for neurologists, for radiologists, and for technologists to learn for the intracranial mass effect, which one that you need to notify your radiologist or your clinician. And this talk is going to be like an interactive session. So please prepare your a cell phone, and we're gonna have a QR code for you to scan and do an interactive session. This is your third time maybe that you give lectures for us, because first time you gave a lecture in Thailand in 2017,
right?
Second time in 2019 during a pediatric neuro course of the iAOC, right? And this is your third time. And after those two lectures course in Thailand, you have your fan base, your FC. Not only because you have a very good lecture and have your FC, your fan base, but because also you look like a very popular Thai singer, Stem Apiwat. Yep. Okay, so please welcome Dr. Wu, and you can start your talk now. You can share your screen.
Okay, let me go to share screen. Let me find here we go. Okay, can everyone see this okay?
Yes, we can see it okay.
Good. Okay, hi, good morning everyone. My name is Isaac Wu. I'm from Indiana University. Thank you, Tanya, for this very, very kind introduction. And thank you, iAOC, for this invitation to give this lecture. So today, the topic, as Tanya talked about earlier, is that this is a neuroimaging for non-neuroradiologists. So if you're a neuroradiologist, I think this might be a little bit too basic for you, but for everyone else, I hope this is a very helpful section. So basically, we're going to talk about how to recognize dangerous intracranial mass effect. So if you are a radiologist tech, for example, if you scan the patient, you see something that looks very abnormal, I encourage you to talk to your radiologist right away. If you recognize it, just make sure the patient is doing okay, because at the end of the day, we are all worried about patient care. So let's get started. So I'd like to start with two cases here. Just for example, you have two patients right here. This image right here, patient A and patient B. This is MRI of flare sequences. The exact sequence is not very important, but I think that you can easily recognize there are two lesions with these two different patients. Now, both patients had very similar background. Both of them are very young, in their 20s. Both of them are HIV positive. And of course, you can see both of them have this abnormal looking lesion on flare. It's very bright on flare. Can you tell what's the difference between these two, other than the size of the lesion? It's very similar. And if you look at this lesion right here, hopefully that you'll recognize for patient A, even though the lesion is quite large, you don't really see mass effect. You see the lateral ventricle still looks very nice and open. What's on the left look like what's on the right. For patient B, you can see quite a bit of mass effect. the right lateral ventricle is being compressed. So the major difference on this picture here, you can see, is patient A has mass effect. Patient A does not have significant mass effect, but patient B does. So it turns out intracranial mass effect is very important for patients' prognosis, for patients' treatment, how a patient is going to do, and also for differential diagnosis. So that's what we're going to cover today, how to recognize dangerous intracranial mass effect and some of the differential diagnosis. And for diagnosis, patient A here without mass effect, patient has PML, patient B has CNS lymphoma. Unfortunately, both patients pass away a couple months after diagnosis. So let's talk about intracranial mass effect. Okay, this is a part that we're going to try this interactivity. If you have a smartphone, your iPhone or Android phone, and you should be able to point your camera at this QVC code, and a question should pop up. So let's just go for a test. I just want to get to know the audience. Can you tell me who you are? Are you a neuroradiologist? Are you a radiologist but not a neuroradiologist? Maybe a resident in training? Are you a technologist? Or are you a physician, neurologist, or you're from different field, different field physician, or are you a medical student or other medical professions, and or are you not in the medicine? You just want to log in and for fun, try to learn. Maybe you're bored on Saturday morning or Sunday morning, you want to learn something about medicine. So hopefully that you're able to see the questionnaire. Okay, so I have getting some response, and let me just share you with what I see. Good, so many of you are radiology residents, so welcome. And some of you are radiologists and physician from other field, and one of you is not from medicine. Welcome to the conference too. So great. So good, it's working. So let's continue with that. So welcome everybody, good morning. So for basic approach of neuroimaging, just for in general, when you look at neuroimaging, I think you hear this before, radiology is like real estate. It's all about location, location, location. Like when you're buying a house, you want to make sure that it's in the best location. The location is the most important thing. The first thing about location you want to know is if you see a mass lesion, it doesn't matter if it's a tumor, it's a neoplasm, it's blood or infection or anything. The first thing that you should determine is if the lesion is intraaxial or the lesion is extraaxial. What does that mean? That means that there's two patients right here. Patient A, you can see there's a lesion that's expanding the gyri. So you can see that the lesion is coming from inside of the brain. That is intraaxial. So intraparenchymal is intraaxial. Patient B, on the other hand, you can see this lesion is outside of the brain parenchyma. It's pushing the brain parenchyma away. So this lesion right here is extraaxial, so extraparenchymal. And that is very important. That's the first thing that you should do when you see a brain imaging, you see a mass. You want to see if it's intraaxial or it's extraaxial. Why is that important? Because that helps with your differential diagnosis. For example, does anyone know what is the most common extraaxial tumor in adults? Is it A, metastasis? Is it B, meningioma? C, multiple myeloma? D, GBM? Or E, lymphoma? So knowing whether or not a lesion is intraaxial or extraaxial is important. So what do you think is the most common adult extraaxial mass? So I'll give about 10 seconds to see if you have time to come up with a few answers here. and for trainees, radiology training and medical students, and a lot of the medical knowledge will translate into imaging findings. So knowing some of the important medical knowledge can help us make the correct diagnosis. So for us, we are not just looking at images. So good. So this is a response. So very good. Most of you picked meningioma. Great. So the answer is meningioma. Good. So by far the most common type of extraaxial tumor, even more common than metastasis in adult, is meningioma. So that's why it's very important to determine if a lesion is intraaxial, extraaxial first place. So in adult, if you think about intraaxial, if the lesion is coming from the brain parenchyma itself, then the most common type is metastasis. It's a secondary tumor. So metastasis come from elsewhere. Lung cancer, breast cancer being the most common ones. The most common primary brain tumor is GBM, glioblastoma multiforme. And we mentioned earlier, if you can decide the lesion is extraaxial, then the most common one will be meningioma. So knowing the location is very important for differential diagnosis. Another location that we like to determine is whether or not the lesion is supratentorial or infratentorial. In other words, is it above the tentorium or below? And this is important for kids versus adults as far as the neoplasm tumor is concerned. In kids, in pediatric patients, majority of the tumor are infratentorial, and in adult, majority are supratentorial. So that location is important. Also for mass effect, tentorium is a very important structure. As you know, tentorium is very, very tough. So it's very difficult for any type of lesion to try to break through the tentorium. So you can imagine if you have a mass effect in the brain parenchyma will be pushed inside and down. So across the tentorium, transtentorial herniation. So very few lesions is strong enough to break through the tentorium. So that's also an important structure. And the last location, of course, is a specific location, like is a lesion in the frontal lobe, parietal lobe, or intraventricular. So those are the basic approach when you first start off seeing a brain mass. Again, it doesn't matter if it's a neoplasm, infection, or hemorrhage. Decide if it's intraaxial versus extraaxial. So let's look at intracranial mass effect. Here you have 3 patients. All 3 patients has the same pathology. Patient ABC, you have a non-contrast HCT. Hopefully something will catch your eye right away when you see this. And as a technologist, for example, when you're scanning the patient, when you see an abnormal mass effect, hopefully you will alert your radiologist right away, say, hey, there's a mass effect. This can be potentially very dangerous for the patient. So that's why it's important to recognize a mass effect. So what catches your eye between A, B, and C? 3 different patients with same pathology. So hopefully it's a mass effect. Here you can see if you draw a midline, clearly the midline structure has been pushed from right to left. So very, very abnormal, large mass effect. And for patient A and for patient C, you can see that the pathology is very easily visualized because you have a strong contrast. The lesion looks very different than the brain parenchyma. For patient B, though, it's much harder to see, isn't it? So this is what we refer to as isodense lesion. Isodense meaning that it's the same density between the lesion and the brain parenchyma. And those are the ones that's most difficult to see. And hopefully that you will recognize a mass effect. Then you would know that there is a lesion hiding in there. So that's why I recognize mass effect is also very important for your diagnosis. And for this case, this is acute blood, acute, subacute, and chronic blood. As many of you know, acute blood has a higher density. So if you look at this graphic up here, the gray matter is about 40 Huntsville union, white matter is about 30. So that's why you can tell the difference between the gray matter and the white matter. But the first lesion right here, the density in the acute phase is much, much higher, it's about 80 and above. So the acute blood is very easily seen compared to the brain parenchyma. In the isodense stage, though, now you can see the problem. The subacute blood has exactly the same density as gray matter and white matter. That's why they are invisible on non-contrast CT. So hopefully we can recognize a mass effect, then we know that there's a lesion here. Then when the density decreases in the chronic subdural hematoma, again, the lesion becomes very, very obvious compared to the brain parenchyma. So as you know, many of you know that acute blood is bright, hyperdense, chronic isodense about 1 to 2 weeks, and when it become, subacute, when it become chronic about 3 weeks or after, it become low density compared to the brain parenchyma, so hypodense. So for radiologists and radiologist training and many physicians, that you do need to know a very precise neuroanatomy. But I think when you first start off, just look at images. I think it's a one quick way you can do is follow a couple of key levels. Look at those levels and recognize whether or not there's abnormal mass effect. So the 4 key levels that I like to focus on would be foramen magnum, brainstem from inferior to superior, foramen magnum, brainstem, basal ganglia, lateral ventricle. What you want to do is that you want to compare side to side. What's on the right should look like what's on the left. And you want to look from front to back, and you want to look all around. So the gray-white matter differentiation should be intact, the cell size should be intact, and the cisterns and the CSF spaces, ventricles should stay at midline, not deviated to one side or the other. So let's focus more closely on each individual level. So start off from the lowest level at the level of foramen magnum. The first thing that you notice is that at foramen magnum, you should be able to see centrally a density, that's spinal cord, of course. It should be a little bit denser than the surrounding CSF. You should be able to see that. If you see the entire foramen magnum is filled with soft tissue density, you may be seeing cerebellotonsillar herniation. So you want to be careful. On the next level above, in the level of brainstem, specifically midbrain. Midbrain, some people think look like a Mickey Mouse. The ear of the mouse is crus cerebri, or cerebral peduncle. Anterior to the Mickey Mouse, you have a very important star-shaped cistern, supracellular cistern. You want to make sure that it looks like a star. Sometimes if one arm of the star starts to disappear, you may be seeing the early sign of uncal herniation. Behind the Mickey Mouse is always smiling, right? You have a quadrigeminal cistern, that's a flat portion right here. The corner of the smile, that's the ambient cistern. Behind that, you have fourth ventricle, should be nice and small like that. On each side of the medial temporal lobe, you should be able to see temporal horn. Remember, temporal horn is the most dependent portion of the lateral ventricle, so they should be small and symmetric. One level above, at the level of basal ganglia, first of all, you should be able to see the quadrigeminal cistern and ambient cistern again, the spine-shaped cistern. And you should be able to inspect lateral ventricles. They should be small and symmetric, same size. What's on the left should look like what's on the right. And also, they should stay at the midline. Lateral ventricle go through foramen magnum, foramen Monroe. And the third ventricle is a small straight line on the axial view. Should stay at the midline. And you should be able to recognize all the individual basal ganglia. You have caudate head, you have basal ganglia or lentiform nuclei. Medially, you have globus pallidus. Laterally, you have putamen. And you have a thalamus that's separated by the internal capsule. So those are the images on CT I will inspect every single patient. And further level up at the level of the lateral ventricle, you should see the lateral ventricle, they should be symmetric inside, about the same size. And also, if you draw a midline, they should stay right at the midline. it should not be deviated to one side versus the other. So whenever it's been pushed to one side, then maybe you have a mass effect on that side. And sometimes on head CT, we also get sagittal view. When you have that, make sure you look at the level of foramen magnum. The cerebellar tonsil should be positioned at the foramen magnum or above. If it's below and in an acute setting, you may be seeing cerebellar tonsil herniation. So you have to be careful about the position of cerebellar tonsil. Cerebral aqueduct is from third ventricle into fourth ventricle. And as you know, fourth ventricle look like a triangle on the sagittal view. You want to make sure all those structures are open. So those are the key level that I will inspect every single images. Of course, that you should always inspect every images, not just this 4 levels. But if you want a quick way to just inspect mass effect, I think those are good levels to look for. So what about mass effect in general? What do you look for? Well, in general, you want to look for sulcal effacement, meaning that are all the sulci, the sulcus, are they open? And you want to look for shifting of the midline structures. Is there any midline shift? Things are shifting to one side or the other side. And then we will talk about individually about different type of brain herniation. So for example, sulcal effacement. In this example, you can clearly see there's a large acute subdural. Remember, acute is hyperdense, it's bright compared to brain parenchyma. So you have a diffuse acute subdural hematoma on the right side. Since it got pushed to the left, if you look at the left side without mass effect, all the sulcus or the sulci is very visible and open. Compare that to the other side. There is diffuse sulcal effacement. So all the sulci become very crowded. So that should give you a clue that you have a large mass effect. And in this case, you can also see the ventricle is more compressed. So what's on the left side does not look like what's on the right side. And also you see there's shifting of the midline structures. So if you draw a line down the middle, you can see the septum pellucidum should be in the midline, but in this case has been pushed from right side to left side. So those definitely, when you see that, you have to be very careful, make sure you're not missing a large mass effect. And in this case, again, it's due to acute or hyperdense subdural hematoma. And let's look at some of the brain herniation pattern. And those are the herniation pattern that everybody needs to recognize. Before we get there, let's talk about a few more anatomies before we get there. And I'll give you some clinical example of what we see on daily basis that from our patient that we see here in Indiana. What about this question? What if I ask you a question for the oculomotor nerve, the cranial nerve 3, innervates multiple different muscles, and this is something that we all learn in medical school. It innervates many different muscles, every single one except which one does oculomotor or cranial nerve 3 does not innervate. Is it lateral rectus, medial rectus, C superior rectus, D inferior oblique, or E levator propria superioris? So what do you think? This is something that we all learned anatomy back in medical school. And some of the stuff that if you don't, if you haven't studied for a while, you tend to forget. A lot of small anatomy, sometimes I forget. I have to look it up too. So let me give you 10 more seconds. Here is everyone's answer. I hope you can see this screen. Majority of you picked lateral rectus. Good job. So it is lateral rectus. When I was in medical school, we have this mnemonic called SO4LR6. Honestly, I don't know what that means, but it's something that I just remember. Sounds like a chemical, some type of chemical code. So, but the mnemonic SO4, meaning that the superior oblique is innervated by fourth cranial nerve, lateral rectus, LR6, is innervated by sixth cranial nerve. Everything else is innervated by cranial nerve 3. So that's why cranial nerve 3 is such an important nerve, that because it innervates so many of the muscle in the orbits. The importance here that I want to point out is, notice that the course of the third nerve in relationship to ungus, or the medial part of the temporal lobe. So if you have an uncal herniation, if you have a mass effect that's causing ungus to go in this way, you can imagine that there's a potential the third nerve can be compressed. Therefore, you can present lots of certain third nerve problems or third nerve palsy. So for example, if you have a third nerve palsy, third nerve is being compressed, that means that potentially all this muscle can be damaged or dysfunction. So medial rectus, for example, is not working. So your eyeball cannot go medially, so cannot have abduction. On the other hand, you still have a unopposed option action from lateral rectus, because sixth nerve still intact. So your eyeball will go laterally. So you present something look like down and out. So lateral deviation and inferior deviation. So that's a sign of third nerve palsy. Also, because of the sphincter papillae muscle is damaged, you can have pupil that's dilated. So-called blown pupil. So pupil is abnormally dilated and will not react to light. If you shine the light in the patient, the pupil will not react, just remain dilated. Also, because of the levator papilla muscle, now your eyelid cannot open. So patients tend to present with ptosis. So eyelids remain closed. So this becomes a typical picture of what cranial nerve 3 damage can look like, third nerve palsy. When you see that, one of the causes that you should consider is uncal herniation. Another common cause, of course, is aneurysm that's compressing, particularly posterior communicating artery aneurysm. Also, as far as the relationship between the major intracranial arteries, let's look at ACA, MCA, and PCA. So the basic vascular anatomy that we all learn. For PCA, again, the ungus, the medial portion of the temporal lobe. If you have an uncal herniation, mass effect, medial part of the temporal lobe become deviated this way, there is a potential that you may compress on the PCA, causes a PCA infarction, so occipital lobe infarction. So when you have uncal herniation, one of the complications that you need to look for is PCA infarction. For ACA, anterior cerebral artery, for ACA, because its relationship right next to the falx cerebri, if you have a subfalcine herniation underneath the falx, there's a potential that the ACA can get compressed. So you can have an anterior cerebral artery compression and anterior cerebral artery infarction. So the medial part of the frontal lobe, you may have infarction. So when you have a subfalcine herniation, you have to look for ACA infarction. Okay, good. So let's switch gear. Let's talk about brain herniation. There are major patterns. Let's say, in this case, there's foreign object thrown at this cartoon. The patient developed a large epidural hematoma. So there's an extraaxial hemorrhage. You can see there are multiple mass effects. There are many different types of herniation pattern. There are a couple ones that I like to focus on this lecture. The first one is subfalcine. So herniation underneath the falx cerebri, subfalcine herniation. The second type is called central herniation, meaning that you have a mass effect that's so massive, the entire brain is swollen, so everything got pushed down. So bilateral transtentorial herniation. Another major type is unilateral, so one side. In this case, the left side, uncal herniation. Remember, the medial part of the temporal lobe is called uncus. So you have a uncal herniation or transtentorial herniation across a tentorium. The last one, if you have a mass effect in the posterior fossa, you can push the cerebellar tonsil below, like that, and then you can cause crowding, obstruction of CSF at the cranial-cervical junction, and that's tonsil herniation. So let's go through some of the case scenario deal with this type of herniation. So let's, for the next 20 minutes or so, let's finish up with some clinical example. And these are the cases that we see at Indiana, and you will see this in your hospital as well. So those are the example of brain herniation. So the patient one, for example here, the patient's a 48-year-old female. She has a chronic headache. She had this headache all her life, but according to her physician, that her chronic headache has become worse for the past 8 months. So it's getting worse. She also now has problem with vision, diplopia, double vision, and she's complaining about her left side weakness is getting worse and worse and worse. So that's something new also. So the symptom here is quite concerning. And on the physical exam, the physician noticed that the patient has a right pupil that's dilated. Remember, now you start thinking about what's going on here. Her right eyelid cannot open, so she has ptosis, and she has right eye that's down and out. So at this point, you should recognize that the patient has third nerve palsy. And on the left side, she also had left side weakness. So what's going on here? And the physician who examined the patient became very concerned, and as he should, so he ordered a head CT, and we read the head CT, and we call him and say, hey, your patient looks very abnormal, so you probably want to send the patient to emergency room, and there they get an MRI. This is a patient's MRI. On top right here, this is just normal picture for your reference at the same level on CT. On the bottom is a patient's MRI T2-weighted sequence. So from the inferior level, as you can see, at the level of midbrain, remember the Mickey Mouse? You can see the right side of the Mickey Mouse ear is being compressed. So clearly, of course, you can see the large lesion. But if you just focus on the mass effect, the right cerebral peduncle is compressed compared to the left side. So, and also here, let's look at this axial view again. Remember the star-shaped cistern, the suprasellar cistern? On the left side, you can still see a star. But on the right side, the star has been compressed. So whenever you see that, it's much easier to see on MRI, of course. But if you see it on CT, same type of picture, you really want to be concerned about transtentorial herniation. And on the level of the basal ganglia right here, you can clearly see that the lateral ventricle is compressed. And often when you have a mass effect this big, you would have a dilatation of the ventricle on the other side. You have obstruction of Freeman Monroe here, and there's a midline shift. Even up here on the third level, you can clearly see there's a midline shift. If you draw a line down the middle, there's a right to left midline shift. The transtentorial herniation is much, much better seen if you have a coronal view. Here you can see the tentorium. If you look at the normal side, the uncus, the medial part of the temporal lobe, should be above and medial inside of the tentorium. But if you look at the abnormal side, clearly you can see the uncus is being pushed medially and inferiorly. So this is a very, very clear case of transtentorial herniation. And why does a patient has a left side weakness? And I think most of you also know this, is that because of corticospinal tract is decussate or crosses at the level of medulla. So if you have a mass effect, in this case on the right side of the corticospinal tract, it crosses midline to the other side, so that way you can present with a left side weakness, just like when patient has an acute stroke. When you have stroke on the right side, patient will present with a left side weakness. So in this case, corticospinal tract is being compressed on the right, and that presented with a contralateral, meaning that different side, opposite side. Ipsilateral is the same side, contralateral is the opposite side weakness. So right-sided lesion presented with a left-sided weakness. So as far as the triad for transtentorial herniation, you can see blown pupil because of third nerve palsy. You can see a contralateral weakness because of compression of the corticospinal tract on the same side, and compression of the brainstem, midbrain, something can cause also respiratory distress, coma, etc. And remember the relationship between PCA and the ongus. And you also want to look for PCA infarction as a potential complication. And in this case, patient is okay. We don't have a PCA infarction, even though the PCA is being deviated, it's being compressed. As you can see, again, the relationship between PCA, posterior cerebral artery, and the medial part of the temporal lobe, the ongus. So that's a PCA right there. But patient is okay in this case. Let me show you a different case. In this case, it's a different patient with 67-year-old male. This is non-contrast HCT. You can again see something is very, very abnormal up here, a large lesion, cystic lesion with a lot of edema. You can see a midline shift. Everything is pushed to this direction. And on CT is much harder to see, but the supracellular cistern should be right here. But I really don't see it at all. And you can see there's uncal herniation. But notice what's going on here in the occipital lobe. This patient does have a PCA infarction from uncal herniation. So that's part of the potential complication that you should look for when you suspect a uncal herniation. And again, just for a reminder, the PCA, posterior cerebral artery territories, is involving the occipital lobe and the medial posterior aspect of the parietal lobe. Okay. Even though more commonly we talk about this, in this case, for example, right, the lesions on the left side. And the typical presentation is that because the left corticospinal tract is being compressed by the ongus, you have a right-sided weakness, contralateral weakness. That's a typical picture. But sometimes you can present it with a ipsilateral. So the weakness is on the same side. And how does that happen? And that's also referred to as false localization, because you expect the weakness is on the other side, but sometimes the weakness could be on the same side as a lesion. And that phenomenon is called Kernahan's notch phenomenon. So what happened is, when you have a mass effect that is very powerful, you are pushing the brainstem all the way from left side to the right side. So at the level of tentorium, you can create a notch. That's Kernahan's notch. So when that happens, because you have a mass effect against the contralateral corticospinal tract, now you have a symptom that's on the same size of the lesion. So don't let that fool you clinically, that sometimes a mass lesion can produce a weakness on the same side as a lesion. And it used to be much more difficult to localize the weakness. But nowadays, because you can get CT, you can get MRI, that's not so much an issue because you can clearly see where the lesion is. Okay, so let's focus on the second type of herniation. So this is another patient that we seen a couple years ago. It's a young patient, a 17-year-old male, comes in complaint of severe headache for 3 days. So the patient come to our emergency room 3 days ago. He was examined by the physician, and they did get a head CT at that time. The head CT was negative, So at that time, they said there's nothing abnormal about the head CT. The patient was sent home. I think was treated with some medication. The patient sometimes get a little bit better, and they send the patient home. The patient 3 days later come back to emergency room again, talk about this severe headache that's getting worse. But now the patient is complaining about double vision. So he's seen her diplopia and also feel this more drowsy for the past few hours. So his roommate become concerned, so take him back to emergency room. On physical exam, now remember 3 days ago the patient was okay. The patient was normal other than severe headache. They couldn't find anything that's wrong. But on today's physical exam, they look at the patient, it's very different. Now the bilateral pupil is dilated and non-reactive. And during the exam, the patient become worse and worse and worse and developed respiratory distress, and the cold was cold, and patient actually got intubated because patient went into respiratory distress in ER. And on physical exam, it was documented that patient has a very minimal movement to the extremity to pain. So it looks very, very concerning exam. And unfortunately, when they did a head CT, this is what they found. In the level of midbrain, basal ganglia, and the lateral ventricle, the 3 key images. So what do you think happened to this patient? Remember, the patient 3 days ago was scanned with a head CT, and the head CT was normal. But obviously today is very abnormal. So what do you think happened to this young patient? So patient did not have trauma, so I'll give you A as not the answer, but that's obviously a concern. But remember, 3 days ago, patient was already feel bad, so there's no signs of trauma. But could this be rupture AVM? Is this rupture aneurysm, amyloid angiopathy, or meningitis? I think I accidentally give away the answer. So let me see here. Change so I think good, most of you, Roger. So it's let's talk about this a little bit. So many of you choose rupture aneurysm, and slightly majority of you choose AVM too. So let's talk about that. So I think that's a very good point, is that whenever you have a patient comes into your hospital in an emergency room and there's acute hemorrhage like this, one of the concerns, of course, you have to worry about is rupture aneurysm. But why is it the better answer is AVM? Remember the first thing we talk about, the location of the lesion, location. In this case, if you look at this hemorrhage right here, this hemorrhage right here is intraaxial. So it's parenchymal, intraparenchymal hemorrhage. For rupture AVM, they tend to present as a subarachnoid hemorrhage. So in other words, the rupture aneurysm, they tend to present with extraaxial blood. It's unusual. It can happen, but it's not typical to have a rupture aneurysm presented as an intraparenchymal or intraaxial hemorrhage. So again, this is a nice case to illustrate that its location will help with your differential diagnosis. And obviously with a young patient, you can still have rupture aneurysm. That's also not as common as older patient coming with rupture aneurysm. So the thing that's most concerning for us will be a rupture AVM. And that tend to present with an intraparenchymal or intraaxial hemorrhage. And as far as amyloid angiopathy is concerned, if the patient is much, much older, in the elderly patient, that's one of the more common concerns, yes. Meningitis, patient can get very sick. Young patient can get very sick with meningitis, that's true, but they don't tend to present, they typically do not present with a massive hemorrhage like this. So the best answer here, or most likely scenario, is rupture AVM. So that's unfortunately what the patient had. And this is a 4-level of exam. You can see that on the level of the foramen magnum, Remember, this is normal patient up here. The normal patient or normal person, you should be able to see a central spinal cord surrounded by slightly lower density CSF. In our case, you can see the patient that the foramen magnum is entirely filled with soft tissue density. So you should suspect there's tonsillar herniation. Here it's a little bit harder to see because you have a lot of blood, but the suprasellar cistern is also not well seen. And then the ambient cistern, quadrigeminal cistern is also effaced. And then you can see there's midline shift. And on MRI, this shows you a better picture, but it's exactly something that we see as a CT. You can see there's hemorrhage, T2 weighted sequence. You can see hemorrhage. By the way, hemorrhage always looks very heterogeneous and very strange on MRI. So for me, it's harder to make the diagnosis of acute blood on MRI sometimes. CT is easier. Here, if you look at the Mickey Mouse ear, the midbrain, right? In this case, you can see the both sides of the Mickey Mouse ear is compressed. So the mass effect is not only from this side, but it's also from this side. The suprasellar cistern should be right here. The star-shaped cistern should be right here, but I don't see it at all. The both sides of the stars has disappeared. So that tells me that there's mass effect from both sides. And also, I should be able to see at the level of midbrain, you should be able to see the smile cistern, the quadrigeminal cistern, ambient cistern. In this case, it's also, I cannot see it at all. Remember, this is T2 weighted image, so CSF should be bright. So I should be able to see a nice cistern right here, but I just don't see it. So this one right here has a central herniation. On the sagittal view, this is a normal person for comparison. Again, when you have a sagittal view, make sure that you draw a line from foramen magnum. The cerebellar tonsil should be positioned at or above the foramen magnum, like that. The suprasellar cistern, the star-shaped cistern on sagittal view look like this, and the smile cistern right behind the quadrigeminal plate, quadrigeminal cistern, should be open. CSF, forced ventricle, should be nice and triangle. You should be able to see a cerebral aqueduct. So that's what a normal patient should look like. This is our patient. If you draw a line on the foramen magnum, you can see that the cerebellar tonsil is very, very far below foramen magnum. So there's a severe tonsillar herniation. Also notice that the suprasellar cistern and the quadrigeminal cistern, just like what we see on the axial view, is completely effaced, is gone. And the forced ventricle is compressed, not like a nice triangle like this. So there's a lot of mass effect that's coming from both sides. And because you also have a compression on the brainstem, see a normal patient have a nice brainstem like this. This one's clearly compressed, and patient also has respiratory failure. And unfortunately for this patient, the patient passed away. The patient died shortly after. And this is a nuclear medicine study. Normally, a brain is very metabolic active. So on nuclear medicine, the brain should be the brightest. In this case, you don't see any activity at all on the nuclear medicine. So this is a brain death study. Some people call this as hot nose sign because all the activity is concentrated. Normally, the brain should be as bright as this. But in this case, because your brain does not have any more activities, look like the nose is very bright. So it's referred to as hot nose sign. That's something that you don't want to see for any patient. So that's a very unfortunate case. Let's switch gear to another patient with different type of herniation pattern. Here you have a 49-year-old patient that wakes up with a AMS, is altered mental status. On the physical exam, patient had left arm weakness, left facial droop, aphasic, patient cannot talk. So I think most of you will already know what that means. So patient has an acute infarction, stroke, and In the States, we also use a different stroke scale, and neurologists would be very familiar with the stroke scale. They assign different number to the symptoms, and based on the number of the scoring system, you can decide whether or not a patient has a moderate, mild, or severe stroke. In this patient is 22, you can see is considered a severe stroke. And this is our patient. A non-contrast head CT. As you can see, there is something that doesn't look very different. Remember, when you inspect the head CT, you should always look all around, and you should compare what's on the left to what's on the right. For example, the ventricle looks fine. What's on the left looks like what's on the right. The midline structure stays at midline, so I don't see a lot of mass effect. But you can see that on this side, you have a complete loss of gray white matter junction. Here you can see the gray white matter junction remains well intact. On this side, you can see there's a loss of gray white matter junction. So the patient has a large MCA infarction, just like what the clinical picture says. And that's hospital day 1. This is hospital day 5. If you scroll through these images right here, now something obviously is very different now than this. You have, again, edema, but you have a hyperdensity here. Now you can appreciate that since there's a mass effect, in day 1, you don't see any mass effect. You don't see a midline shift. But on day 5, now you have a clearly midline shift, compression of the ventricle on one side, and a little bit dilatation of the left lateral ventricle and midline shift. So new mass effect, midline shift, and subfalcine herniation, right to left, midline shift. What do you think is the cause of this new midline shift? Remember, in day 1, patient was okay. Well, the patient's not okay because there's a large infarction, but we didn't see midline shift or mass effect. But in hospital day 5, something clearly went wrong. So what's the cause of this new mass effect? So is it worsening cerebral edema? Is it vasospasm? Maybe some kind of drug that they give to the patient, medication that can cause this new mass effect? Does the patient has new hydrocephalus? Or is the patient has a hemorrhagic transformation? So 10 more seconds. I feel like we should have music during the waiting period. Okay, here we go. So good. So majority of the answer is from hemorrhagic transformation. So that is the correct answer. It is hemorrhagic transformation. And as you know, one of the things that we worry about the most is a large territory infarction stroke has a risk of increased intracranial hemorrhage, especially if you give the patient TPA as a treatment. And also notice that because you have subfalcine herniation, remember subfalcine herniation, the ACA, anterior cerebral artery, is very close to the falx. So if you have a subfalcine herniation, one of the potential complications is anterior cerebral infarction. In hospital day 1, the patient only have a MCA infarction. Now, if you look at hospital day 5, now clearly the ACA territory is also involved. And this is a different patient. The subfalcine herniation, again, of course, is much easier to see on MRI, and especially on the coronal view. Here you can see this mass effect right here from the left side is pushing everything underneath the falx, shifting to the right side. So the cingular gyrus is being pushed under to the other side. And again, that can potentially compress ACA. So whenever you have a subfalcine herniation, one of the complications that you should always look for is ACA infarction. And let's go through the last case where we have additional intracranial mass effect, a different type of mass effect. This is a pediatric patient, and she is a previously healthy 7-year-old girl, now comes in, start to complain about blurry vision, and also has persistent headache for the past couple months. And also more troublesome is that patient has problem with balancing now. Remember, this is a healthy girl, many months ago, start to develop all this new problem. And on the physical exam in ophthalmology, they notice that the patient, look into patient's eyes, they notice that patient has a papillary edema. So right away, they are worried about any type of intracranial mass effect. But unlike our last few patients, her pupil is reactive. Her pupil is not dilated, it's reactive. But patient does have ataxia. So that's also very concerning. And if you see this picture right here on the non-contrast CT, and that's one single image right here, that's at the level of lateral ventricle, remember? So if you just see this single picture right here, what do you think is the most concerning picture for this patient? Why is this patient has all these new symptoms? This is at the level of the lateral ventricle, remember? So what's going on here? Is it because patient has an uncal herniation? Maybe B, patient has subfalcine herniation. C, patient has subacute subdural hematoma. Maybe it's one of those isodense blood that we cannot see. Or D, maybe patient has obstructive hydrocephalus. Or is it E, patient has macrocephaly? Maybe the problem is that her head size is getting too big. So what do you guys think? So fantastic. I think I cannot fool anybody. Everybody see that even though, so everybody answer obstructive hydrocephalus, that's exactly what's going on. So even though there's symmetry, what's on the left look like what's exactly on the right side. There's no midline shift. So there's no subfalcine herniation. But the ventricle for a 7-year-old girl is definitely too big. So right away, you should be worried about obstructive hydrocephalus. Then, of course, when you scan the patient, and we can see the cause of the obstructive hydrocephalus here. Now, the third ventricle is also dilated, so you know the obstruction is coming from below. In this case, you have a large area of abnormal signal or density in the posterior fossa. So we scan the patient and also notice that at the foramen magnum, this foramen magnum is also very crowded. There's all soft tissue density, so there is tonsillar herniation also. And that's not a surprise because the majority of the mass effect is coming from the posterior fossa. So of course, when you look at the sagittal view, the things are much, much more clear. You can see that there's a compression of the fourth ventricle. This, by the way, is not fourth ventricle. This is a part of the tumor cyst. And if you draw a line on the foramen magnum, you can see the cerebellar tonsil is definitely much lower than it should be. So there's tonsillar herniation. And of course, you know, right away, you will get an MRI to get a better characterization. And this shows exactly the same thing as on CT. Again, this bright signal right here is not fourth ventricle. This is part of the tumor cyst. The fourth ventricle is being compressed. You can't really see fourth ventricle anymore. Here you can see tonsillar herniation. And in this case, you actually have a brain that's been pushed above the tentorium. So this is another form of transtentorial herniation, but in this case, it's not a downward herniation, but upward herniation. So you have obstructive hydrocephalus. So as a last part, let's talk about hydrocephalus just a little bit. When you see hydrocephalus, You see a big ventricle. But the first thing that you should ask yourself is, can CSF escape from the ventricular system? In other words, do you see any obstructive lesion at any point between lateral ventricle to third ventricle and third ventricle to fourth ventricle, or in our case, the case I just showed you, obstruction at the fourth ventricle outlet? If the answer is no, you do not see any type of obstruction, then the enlargement of the enlargement of the ventricle is due to non-communicating hydrocephalus. I'm sorry, I got that backwards. When you ask the question, can CSF escape from the ventricular system? In other words, do you see an obstruction, right? So CSF cannot escape from the ventricular system. So there is an obstruction. So in that case, that's the non-communicating hydrocephalus. In other words, that's the same thing as obstructive hydrocephalus, like the case we have. Sorry, I think my wording is a little bit strange here. But if the CSF can escape from the ventricular system, if you don't see any point of obstruction, that means that patient has a communicating hydrocephalus. There's no obstructive lesion. In that case, another question that you should ask or try to find out the history is that, is there any problem with CSF absorption at the level of the arachnoid villi? For example, is there any history of meningitis or subarachnoid hemorrhage that's blocking the absorption of CSF? If the answer is yes, then you have a communicating hydrocephalus. If the answer is no, there's no history like that, then maybe you're looking at special case. For example, in older patient, you're looking at normal pressure hydrocephalus. And in kids, sometimes you can have a tumor that can produce CSF too quickly. And that's such as chorioplexus carcinoma, chorioplexus papilloma. So those are the special cases that you should be worried about. So whenever I see a large ventricle hydrocephalus, those are the questions that I ask myself. That's all. Let's do a quick summary of different patterns of brain herniation. So you see, again, on top row right here, those are the normal 4-level slice: foramen magnum, midbrain, basal ganglia, lateral ventricle. So which patient A, B, C, D? I don't have a polling question here, but you just have to answer. You think to yourself, which one has subfalcine herniation? Is it A, B, C, or D? Subfalcine herniation. I think when you're looking for subfalcine herniation, look for midline shift at the level of lateral ventricle. So in this case, is patient D has subfalcine herniation. Make sure that the lesion does that, or the structure stay at midline, no midline shift. What about which patient has uncal herniation, unilateral, one-sided uncal herniation? And that's where you want to inspect at the level of midbrain, star-shaped cistern, the supracellular cistern, and patient A right here, clearly you have a supracellular cistern that's one side is being effaced. What about tonsillar herniation? Remember, looking at the level of foramen magnum, right? You should have a density in the center, spinal cord surrounded by CSF, hypodense CSF. And in this case, when you see the entire foramen magnum is filled with density, soft tissue density, then that's tonsillar herniation. And lastly, central herniation is the central one right here. The entire supracellular cistern is disappeared, compressed on both sides. The cerebral peduncle on both sides is being compressed. So those are the patterns that you should be able to recognize. That's all. I hope this is helpful for you. And if you have any questions, please email me. Feel free to email me at email right here, or contact Dr. Subaku. And then if you have any question, I'll be happy to answer. Thank you very much.
Thank you so much ขอบคุณมากค่ะ Thank you
Thank
This is
you.
really impressive lecture Isaac because like you give like a fundamental concept of the most important thing that like technologists radiologists or like every MD should know about this. So you have like a one student from Bhutan watching the on the Facebook Live right
Oh,
now.
good.
Yeah, and I
Welcome.
also have one question for you from like it's like from the Zoom audience. So
Yes.
thank you so much, Professor. How can you differentiate central herniation, descending transtentorial herniation, and ankle herniation?
How do you differentiate?
Mm-hmm.
So yeah, so it's all from the pattern. Let me see if I can get back to the slides right here. So it's a lot of time. Please keep in mind that when people give you presentation like this, they always show you the prettiest picture, the most beautiful picture that they can find. In real life, you're going to come across a picture that's not as pretty as this. So in real life, it's not as easy as we like to make it sound to be. So I think that's one of the number one thing to remember. But for this different key level right here, I think it's very important. For example, if you're looking for central herniation, what you want to make sure that is all the supercellular cistern and the quadrigeminal cistern and ambient cistern, they are all open, meaning that it should look exactly like CSF. Right? You can always find CSF is your internal reference. So on MRI, on CT, CSF is always the best place to go. For example, this picture right here, you know CSF is going to be bright because it's T2 and you know where to look for CSF. Now, all this space, if in this case, for example, patient A right here, if the supracellular cistern, the star-shaped cistern, one side of them is start to disappear, or the quadrigeminal cistern look like it's being compressed from one side, then that is more of the ankle herniation. Just means that it's one-sided. If both sides is gone, like this, so that's a bilateral. So that would be more central herniation. So in other words, ankle herniation is from one side, central herniation just from everywhere on both sides. So that's kind of the key distinction. And also clinically, their picture is different. In clinically, for ankle herniation, you're going to present with a one-sided problem. You know, the cranial nerve 3 on one side is compressed, or the other side have weakness. But for central herniation, usually that's a very, very bad outcome. So patient is going to be much, much worse. A lot of time when you have central herniation, when it's this bad, usually patients already been intubated and they are not responsive. So that's another clue. So the clinician also would have a good idea of how really bad this is. And for the I think tonsil herniation, that was a question.
No, it's like a central herniation, descending transtentorial herniation, and ankle herniation.
Oh, ankle. So the descending transtentorial herniation. So transtentorial herniation, ankle herniation is a part of transtentorial herniation. The most common type of transtentorial herniation is ankle herniation. But remember, the tentorium is a big space, right? So they can, for example, this case right here, patient A, you see this back part right here. You can also see the brain tissue that's herniated. That's different than this side. That's part of the transtentorial herniation. That's not uncus. So this is still part of the transtentorial herniation. So ankle herniation is basically just a specific type of transtentorial herniation.
Okay.
I don't know. I hope
yeah.
that makes sense.
Yeah. So does it mean like for central herniation, it mean like a bilateral transtentorial herniation?
Exactly.
Right. Mm-hmm.
Exactly. So both sides being just crowded.
Okay.
Let me see if I can. See if I hope you don't get dizzy. So let's see that. So different pattern right here, for example. So this cartoon is nice because it tells you all the major pattern that you can see. So this side right here just shows you more of a unco herniation, only one-sided. If both sides occur, that will be the central herniation.
And it also means like a descending transtentorial herniation.
Yes. So tentorial just means the tentorium here. So when you have all the tissue, if it's herniated from medially and inferiorly across a tentorium, that's transtentorial herniation. Ungus is just part of the transtentorial herniation. There are also other part of the brain that's in the back or posterior to the ungus. So it's no longer ungus, but they can also transtentorial herniate. So you can think of uncal herniation is just a type of transtentorial herniation.
Yes. Okay, I see. And one thing, as I remember, is like when you see midline shift, it means patients usually have subfrozen herniation.
Yes.
Right.
Typically, yes.
Right. And I mean, like another question is, when we see like a subfrozen herniation or midline shift, and we want to do the measurement and tell the clinician on how bad it is, like how many centimeter or millimeter, which level that we need to do the measurement. Any like a landmark?
Right. I think that's also a little bit of controversial in that I think different people in different textbook will tell you different way of doing it. Personally, I like to use at the level of Freeman-Monroe. So let me see if it, for right at the level of Freeman-Monroe, if you draw a line, and I can use that. Sometimes I say that in my report. I say there's a midline shift at the level of Freeman-Monroe. And some people will use at the level of septum pellucidum. Also draw a midline down here and measure how far that has been pushed one side versus the other. I think the important thing is that, let's say you want to see if the midline shift is getting worse or getting better from day 1 to day 2 to day 3. If you are the same person who reading the exam, you want to be consistent about where you measure your midline shift. Because you don't want to measure one time from the level of Freeman-Monroe, maybe tomorrow you measure from different level, you may come out with different measurement where maybe they look exactly the same, but the measurement may be different. Does that make sense?
Yes.
So I personally like to use Freeman-Monroe, but also I think it makes sense that you may want to choose which level that's worse. Because sometimes we can see a lesion that's very, very superior on the top. So it may cause midline shift, but if you scroll down to the level lower, like in the level lateral ventricle, the midline shift may not be that bad. So in that case, which level to choose, right? At the level lateral ventricle, in this level right here, I think that's also a good level because that's a level where the subfalcine herniation can be seen. So you're just seeing the lateral edge of the falx. So I would either go with this level or this level.
Okay, but I mean, like in the report, we just like need to describe which level that we do the measurement.
I think so.
At least, yeah, we are on the same page.
Yes. Right. And at least that way that, give a reference point. Otherwise, if you just report the number and you have different radiologists report the study, if you measure a different level, you may have a very different number. And when the clinician read your report, they would think that the midline shift is getting worse or getting better. But when in reality is that both of you measuring at a different level. So that sometimes I think that's become a little bit confusing for the clinicians.
I see. Yeah.
So it's all about consistency. Yes.
Yes. One more question. So in terms of like the protocol, because like normally MRI we have like an axial, coronal, and sagittal. It is really easy for us to see like a herniation or mass effect. But for CT, sometimes we have just like axial images. Sometimes we
Right.
have like a coronal and sagittal. So do you recommend at least to have like a 3 planes, axial, coronal, and sagittal, or like a only axial is good enough?
I more and more I'd like to have at least have a sagittal view. So if you have a machine that I know that there are some places that you just don't have a newer CT scanner or software issue, that you may not have the capability to do a 3D volumetric scan and do the reconstructions. But whenever you have a ability to do that, I would encourage you to do at least axial and sagittal. For the sagittal, you can see on the axial view, sometimes you may have something that look like is a tonsillar herniation. But if your scanning angle is wrong or too sharp, sometimes that would look like the foramen magnum is filled with soft tissue density. But if you look at the sagittal view, I think you can tell that for sure whether or not you have a tonsillar herniation. Of course, in kids, sometimes we're not deal with acute tonsillar herniation. We'll deal with something that's more congenital and chronic, like Chiari-1 malformation. And it's always easier if you have a sagittal view that will give you the more precise measurement rather than your best guess on the axial view. So if you have the ability to do axial and sagittal, I would do that. But I'm not necessarily, if you don't have a capability to scan volumetrically and do reconstruction, I would not recommend scan the patient twice, because that's giving patient extra radiation unless it's absolutely necessary. Let's say you see something that's really concerning that you want to get another view, then I think, okay, you can do that, but don't scan every single patient twice so you can give axial and sagittal plane. But if you have the machine and the software capability to scan the patient in the axial view and reconstruction, the same data reconstruction to the sagittal view, and I would do that.
I see. Yeah, I think like right now, most of the hospital in Thailand and I mean like in the neighborhood countries, we have like a helical scan that we can scan like a 3D and we can do a reconstruction. But the reconstruction images, I think it depends on the protocol for each hospital that they going to do it or not. But you recommend at least to have like a sagittal?
I would recommend that. Like when I was training, that we only have axial views.
Yes.
So we try to make all the diagnosis from axial view, and sometimes we have to make a little bit guess. Say, well, like for example, in kids, right? We say there's crowding at the cranial cervical junction. This may represent Chiari malformation. We recommend get an MRI. Right? But if you have a sagittal view at that time, then you can be a lot more definitive. You can say, well, maybe that's just different. That is not a Chiari-1. It's just a way that the scanning angle is too tilted. So I have, and once I start to have a reconstruction, when you start to do that, like 7 years ago, routinely, then I think right now I would be,
yes.
I would make it a lot difficult. I would always ask for a sagittal view if I can get it.
Yeah, I love sagittal view also to see things like for the Chiari malformation and also herniation.
Right, and the midline structure. So I don't necessarily need coronal view because it's so easy to recon now. If they want to give me axial, coronal, and sagittal view, I'll take it. But I think I want at least axial and sagittal.
I see. Yeah. And we also have like one more question. I think it's from a clinician. So she said, thank you so much for the excellent and productive course. How often that CT brain without, how often that CT brain with or without contrast can be missed, the lesion of the AVM? Because I think like you show one patient, 17 years old, that has negative CT at first images.
Right. And turns out that if you look back on the images, which I did not include in this talk, is that it's not entirely normal. It's just that it was, you can consider that as a miss. A lot of time that, especially in ER setting, that we are so busy that we just kind of go through a little bit too quickly than we like. So that's very, very dangerous. The small AVM, though, I would have to say, small AVM is very, very difficult to pick up on non-contrast head CT. The large ones should not be too difficult because you can see some slightly different density. Usually look like they may have, I have seen cases where on non-contrast head CT, some people call cortical malformation because the AVM look very much like a gyroform, look like the gyrus, and it has very similar density to gray matter. So at least some people draw attention to it, say, hey, there's a cortical malformation, concerning for cortical malformation, and they did an MRI, it turned out to be AVM. So you're right, a small AVM is very, very difficult to pick up on non-contrast head CT. And with contrast, it will be a little bit easier because you should be able to see the vessel. Of course, if the concern is high or at least moderate that patient may have AVM, you should always try to do CT angiogram. That would be more definitive diagnosis. But unfortunately, with non-contrast head CT, you can miss a small AVM. But I'm not recommending that everybody should get contrast with and without contrast, because I think that's too much. But if you have some suspicion, if something doesn't seem quite right, if you have high medical family history of AVM, you may want to consider at least give contrast or even go with CT angiogram.
Yes.
And another thing that I understand that, because in the United States, I think sometimes people are a little more spoiled because we can get MRI very easily. MRI, of course, is going to be always, for us, we always love to have MRI. When you have any question, even head CT is normal. Radiologists, head CT normal. We still have, often we have clinicians and neurologists or specialists who feel that something is not quite right. So they would go on order MRI, and then we can pick up small AVMs from MRI. But, of course, the resource sometimes not as easily, as all depend on your setting too. So the bottom line is, yes, a small AVM can be missed on non-contrast head CT quite easily.
Yes. Okay. So let me share. One more question, Isaac. So can you like reiterate about the protocol on the CT? Because I know that like in US, we try to scan patient only one time, either like with contrast or without contrast. So what do you think? I mean, like, do you agree on that part, or like what scenario that we should scan patient 2 times, like without and with contrast?
Right.
Because we know that when we scan patient 2 times, like a double radiation dose to the patient,
yes.
and we try to avoid that.
Right. And then, since Tanya and I, we both work at Children's Hospital, we are also even more concerned about radiation. I think in adult side, they tend not to worry about radiation as much. So you see that more with people who order non-contrast and contrast. I think the question that you should ask yourself when you order exam is that what is the question that you want? What is the purpose of that exam? For example, if patient has a chronic condition, chronic headache, and you were thinking about ordering a contrast and non-contrast first and contrast exam, the only benefit for that non-contrast CT would be acute blood, right? Remember, the acute blood is bright on CT without contrast. So if you give contrast, the entire brain, a lot of vessel is going to be bright. So if you have a small acute blood, you will not be able to pick that up. But if your patient has chronic headache, there's a good chance that you're not worried about acute blood. So in that case, do you really need non-contrast exam? So my answer would be probably not. So if you want to look for a lesion that say, I'm worried about small AVM, I'm worried about aneurysm or any type of stuff or tumor, then maybe you can just go ahead and do with contrast. The only scenario will be in emergency room where a patient come in emergently with, they really don't know what's going on, right? One of the concern they would have is acute blood. Then in that case, you definitely need a non-contrast HCT first. And maybe they also worry about other things like acute infection. Then you need contrast. But the biggest thing for me is that HCT is such a, to me, I think a lot of radiologists here would agree that HCT is more of a screen exam. Mm-hmm. So if you're looking for something that's very, very small, a small lesion, small AVM, small tumor, there's a good chance that even with a contrast HCT, you will miss it or you will not see it. So to me, my personal opinion is that contrast HCT really does not have a lot of, it's useful, but not that useful. Does that make sense? And yes. Part of my opinion is also because I'm come from a place where we can recommend MRI very easily. And the clinician also can order MRI very quickly. So for me, I would start with a non-contrast HCT. If they still worry about that, there's nothing on non-contrast HCT, and they would move on to MRI. But if that's a resource type of issue that you just don't have that ability to get MRI that easily, so I think it's reasonable to get a contrast CT. But if your chief concern is, I'm really worried about acute blood, maybe a rupture aneurysm or trauma, you worry about acute hemorrhage, then you definitely want to do a non-contrast HCT. Because otherwise, if you give contrast, you will miss a small subarachnoid hemorrhage.
Mm-hmm. Yeah, that makes sense.
Yeah, it's a confusing issue. I definitely appreciate that. And in kids, in pediatric population, that we definitely discourage scanning patient twice, just for that. So in kids, we're even more careful about exactly what is your question that you want to answer.
Yes. So that's why with the new technology on CT, like a spectral CT or dual energy, is going to be very helpful in this scenario.
That's where your research is going to be. Yeah.
Yes. So thank you so much, Dr. Wu, for the excellent and very impressive talk. Not only like for Thai student, but also from like a Bhutan and Myanmar student that like attend your lectures. Thank you so much. And yep, ขอบคุณค่ะ. Thank you so much. And hopefully you're gonna come back for us again for the pediatric neuro course. Maybe like a next couple months.
Yeah, we'll try. Okay.
So for the audience who, if you like his Dr. Wu's lecture, so please send like a heart or like a click like on Facebook for him, and you can also like send us like the topic that you want him to teach you, to give a talk, or you want to learn more from Dr. Wu. Thank you so much. Mm-hmm.
I'll be happy to do more. Thank you for your invitation.
Thank you. Yeah. And this is like the last lectures for the module number 2. So next week gonna be module number 3 for chest and cardiovascular. And next week we want you guys to like register again for the next 3 weeks for the chest and cardiovascular lectures. So I'm going to speak in Thai.
Okay. Now. So I'm logging off then. Okay.
No, that's okay. You can be on like on the Zoom. So อาทิตย์หน้านะคะจะเป็นโมดูลใหม่นะคะเป็นเชสแล้วก็ cardiovascular นะคะก็คือจะมีอีก3เลคเชอร์ของอาทิตย์หน้าต้องเริ่มลงทะเบียนใหม่นะคะคนที่เคยลงทะเบียนไปแล้วของเลคเชอร์ของโมดูล2นี่คือจะตัดออกแล้วนะคะก็คือต้องเริ่มลงทะเบียนใหม่เพื่อที่จะได้มาฟังแล้วก็เก็บคะแนน CME นะคะโดยที่หลังจากเลคเชอร์วันนี้เสร็จแล้วเนี่ยจะมีการส่งลิงก์ในการประเมินนะคะในเรื่องของ CME เนี่ยให้ แล้วก็ให้ประเมินให้เสร็จภายในวันพฤหัสตอนเที่ยงคืนนะคะเพื่อที่วันศุกร์ตอนเช้าเนี่ยก็จะได้รับcertificate นะคะของเลคเชอร์นี้ส่วนการลงทะเบียนของโมดูล3นะคะจะเริ่มตอนเที่ยงวันนี้นะคะเนื่องจากหน้าเว็บไซต์ของ iAOC มีปัญหานิดหน่อยนะคะจะมีลิงก์สำรองให้เดี๋ยวจะแปะให้ทาง Facebook นะคะในการลงทะเบียนแล้วก็ในการเรียนของโมดูล3นะคะยังไงก็ขอบคุณทุกท่านมากๆนะคะแล้วก็ยังไงเดี๋ยวเจอกันอาทิตย์หน้าค่ะขอบพระคุณค่ะ Thank you so much Isaac bye bye
Thank you. Bye bye. Good night.
Bye bye